So previously we have studied about history taking in a gastrointestinal system, okay, GIT. So after that we have taken the examination part. So today our class will be mainly on the history taking part of the respiratory system, okay. So the first point is initial enquiry. What is enquiry? So these are only simple and formal questions, okay. And what is inquiry? This is enquiry, na? This is enquiry. What is inquiry? So regarding any matter, when there is an investigation, that time we call it as an inquiry, okay. This is enquiry. So we'll ask just formal questions, the basic questions, okay. Like this will cover the particulars of the patient. What is the particular of the patient? Name, age, gender or sex, then occupation, then address, then his marital status. So in particulars of the patient, what is the importance of the name? Any importance? So if we know the name of the patient, if we call by his name, there a trust, a bond builds up, okay. Okay, a comfortness builds up between the patient and the doctor, okay. What is the importance of the age? So certain group of diseases are more common in pediatrics, okay. Some are in adolescents and in older, some are more common, okay. What is the importance of sex? So if the person is female, so certain group of diseases will be, okay, common in that. And if the patient is male, there are certain group of diseases, okay, which are common in males. So next comes is the address, okay. What is the importance of address? Certain group of diseases are common in particular areas. So by that, knowing the address of the patient, we can identify, okay, whether that patient is from that endemic or pandemic area, okay. Okay, then occupation. Any importance of occupation? So suppose the patient is an worker, okay. He is working in cement industries, or suppose he is even working in a paint industry, okay. Any group of diseases? So certain group of diseases are also, when the patient is exposed to this particular group of occupation, okay, he might develop, okay. It might not be certain, but when he is prolonged working in that area, he might develop, okay. And then another is marital status, okay. Any significance about marital status? So certain diseases are common, okay, if the patient is married, okay, and certain diseases are common if the patient is unmarried, okay. Then this is the particulars of the patient, okay. And then will come the chief complaint, okay. So before asking the patient about his particulars, first of all, when he comes from the door towards your room or towards your table, you must first welcome him, okay, by shaking him, okay, and then letting him sit, and then after that you ask the questions, okay. So in chief complaint, what you will ask? So as this is a respiratory system, so we will be relevant to only the respiratory, okay. So suppose he came with symptoms like coughing, okay, associated with sputum production. Sometimes he having shortness of breath, okay, breathlessness, he is having difficulty in breathing, okay. Sometimes pain also, okay. So how will you describe this? So in chief complaint, it should be in a patient's language, okay. So you have to describe as the patient says, okay, and it has to be in a chronological order. Suppose the coughing is for like 7 days, okay, then he is having shortness of breath since 2 days, so it should be in a chronological order, okay. The maximum duration should be above, and then it will come, okay. Then what about history of present illness? What is history of present illness? Yes. So the present complaints, you have to elaborate them, okay. The present complaints with which he came, like coughing. So how will you describe the coughing, okay? we will see. Okay, so do you know what is cough? So this is a forceful expiration against a closed glottis, which generates a positive pressure in the intrathoracic area, which evacuates the mucus which is formed on our trachea. Okay, this is a positive pressure mechanism. Okay, by this it is expelled. Okay, so is it possible if the glottis is closed to expel it out? It is not possible, na? So there the pressure generates and it opens suddenly, and then the sputum comes out. Okay, so it is a reflex. Okay, so how will you describe the cough? If it is less than 3 weeks, it will be acute. Okay, if it is more than 3 weeks, there are some conditions, okay, where it is acute. Okay, like upper respiratory tract infection, pneumonia, okay, pulmonary embolism. Okay, these are the things. So let's continue. Okay, so how will you describe cough? So if it is acute, it has to be less than 3 weeks. Okay, and if it is subacute, then it is 3 to 8 weeks. Okay, in case of certain viral infections, then post-infective, okay, period. Okay, that time. And if it is more than 8 weeks, it is chronic. Okay, it will come under chronic. So certain diseases like TB, bronchial asthma, COPD, and these cases we see there is chronic cough. Usually the cough persists more than 8 weeks. One term is there, nocturnal cough. What is nocturnal cough? So this is the cough, especially it arises during the night time. Okay, due to this the patient might not be able to sleep properly. Okay, he has to get up and his sleep cycle will be broken. Okay, so this happens in certain conditions like post-nasal drip, okay, where the mucus runs down from the back of the nose to the throat, then chronic bronchitis, bronchial asthma, obstructive sleep apnea, and aspiration. Okay, and the cough might be associated with sputum. So what is sputum? Yes, so when you'll be coughing, okay, any foreign body or any infective organism which might get stuck to your throat, okay, that time if it is not being able to evacuate the particles, it will produce sputum. Okay, that is the mucus. So with this mucus it will be excreted. Okay, so what is sputum? And in sputum we will be asking some questions like what is the consistency? So it is thick or viscous. Okay, then how much amount it is producing, then the color, and is there any postural variation? Postural variation means when he is sleeping or standing or working, okay, that time is it aggravating or not, and the smell. Okay, so in consistency there are certain things like serous, it is clear and colorless, and mucoid, okay, slimy, then mucopurulent. Okay, these are certain conditions where it is found. Okay, like in serous, it is the mainly from the upper respiratory tract. Okay, then bronchial alveolar carcinoma, then mucoid in case of chronic bronchitis, bronchial asthma, then mucopurulent in case of bacterial infections. Okay, mucopurulent means mixture of mucus with pus. Okay, then the color of the sputum. Okay, the color like yellow or green, it indicates bacterial infections. Then black color in cold workers, there we can get the cold workers might exposed to pneumoconiosis. Okay, this might produce black in color. Then pink for the sputum in case of pulmonary edema. Okay, then rusty sputum in case of pneumococcal pneumonia. Then red currant jelly sputum in case of Klebsiella infection. Okay, then blood tinge or streaking of sputum in case of tuberculosis. Okay, so these are certain colors of the sputum which might indicate certain infection, not provisional but definite. Okay, and the color, so color, smell, so the smell might also indicate us like if it is foul smell in case of abscess, lung abscess, then bronchiectasis, then anaerobic bacterial infections. Okay, we might get foul smell. So another symptom is dyspnea. Dyspnea means difficulty or shortness of breathing. This is a subjective. Okay, the patient will tell you. Okay, the in dyspnea you will ask like from when it onset, okay, from when it started, then the duration, since how many days, then severity, whether it was more severe, whether it was less severe, okay, then the aggravating factors, whether it is aggravating and when it is aggravating, okay, during work, during walking or doing any activity, and the relieving factors, what are the factors which relieves it, whether after lying down, okay, at night time, okay, that things. Then postural variation, I told you, okay, and diurnal variation. So certain period of time in the day or in the night, whether it is aggravating or not, okay. Normally we take it in 24 hours, okay. Any part of the day or any part of the night it is aggravating, okay. So this is diurnal variation, okay. So in onset within minutes, okay, some certain conditions like pneumothorax, pulmonary embolism, inhalation of foreign bodies, laryngeal edema. These are certain conditions or diseases where there is onset within minutes, okay. The patient will complain sudden, okay. Then hours to days, okay. This was within minutes, and this is if the patient is having these symptoms or like shortness of breath from hours to days, then we can suspect like it can be bronchial asthma, pneumonia, or acute respiratory distress syndrome, okay. We can suspect. Then like from weeks to months, if the patient is having similar episodes, okay, the shortness and the difficulty in breathing is not subsiding, okay. So in COPD, chronic obstructive pulmonary disease, okay, you all know. So in this case, then like interstitial lung disease and pleural effusion, in these cases we can get onset from weeks to months, okay. And what are the aggravating factors, okay, like when it is during exposure to an allergen, whether it's aggravating, in exercise, drugs, cold weather, whether they are in this condition it is aggravating, we'll ask these questions, okay. Then relieving factors like after taking medication, at rest, it is relieving or not, or after removal of the allergen, okay. Then hemoptysis, one term is hemoptysis. What is hemoptysis? With this complaint, the patient might also present, okay. Hemoptysis means when he is coughing out, okay, the sputum will be mixed with blood, okay, or fresh blood might come out, okay, during when he is coughing. So this is known as hemoptysis, okay. This mainly comes from the lower respiratory system, okay, from the vocal cords, okay, to the alveoli, okay. It might present from anywhere source, okay. So certain conditions where it might present, okay, like most commonly we can see in tuberculosis, okay. The patient of tuberculosis might present you with hemoptysis, okay. Then in case of lung abscess we can get, in case of bronchiectasis, then pneumonia, then fungal infections like aspergillosis, blastomycosis, okay. And so in these cases this patient might present to you with hemoptysis, okay. So another thing is chest pain, okay. If the patient is complaining of chest pain, then how will you describe the chest pain, okay. So one mnemonic I already discussed in the gastrointestinal system. Anyone remember how to describe pain? One mnemonic was there. If anybody have noted down or still remember, yes. So it's SOCRATES, okay. SOCRATES, this will cover all the things by which you will be describing the pain, okay. SOCRATES means as for site, okay, from the location from where the pain is started, okay. Then O for onset, yes. O for onset means since how many days or the duration the patient is complaining, okay. Then C for character, so the character of the pain, whether it is dull aching, whether it is stabbing, whether it is puncturing, okay, the type of pain, okay. Then R for radiation, okay, whether the pain is radiating to any side, okay. Then suppose it is radiating towards the back or towards the neck, okay, we'll describe it on radiation. Then A for association, okay, so whether it is associated with other symptoms, okay. Then T, what is T? T for, okay, here one thing is aggravating factors and one is relieving factors. Okay, so this will come here. Okay, so E is for so here aggravating and relieving factors will come. Okay, the last one is S na. S is for severity. Severity. So how will you score the pain? So how will you score the pain? It will start from 0 with no pain, and 10 means unbearable pain. Okay, you have to score the pain. So this mnemonic will cover all the things. Okay. Another term is retrosternal pain. Okay, retrosternal pain means if the patient is complaining there is pain specifically from the sternum or behind the sternum. Okay. Okay. So some conditions are like if the patient is complaining mainly from the upper side, it might be a tracheitis. Okay. Then from mid or lower, it might be mediastinitis. Okay. So one more term is there in pain, that is pleuritis. Pleuritis means inflammation of the pleura. Okay. So this will be catchy pain, and it will increase in deep inspiration. Like when the patient is complaining of pain, when you tell the patient to take a deep inspiration, the pain will be sudden. Okay, catchy pain. Okay, it only arises during deep inspiration. Okay. So some causes might be COPD, then pneumothorax, then hemothorax, pulmonary embolism. So in these cases, you might get a pleural pain. Okay, that is pleuritis. Okay. So this way you have to describe the history of presenting illness. Okay. So after that comes what? Past medical history or his past illness. So in past illness, what will you ask? If the patient is having similar episode or any from particular disease the patient has suffered from, or whether he was hospitalized. Okay, that things. Okay. Yes. Okay. Then any surgical history also, whether there was any operation. Okay, these things. Then comes family history. Okay. Then what will you ask in family history? Is there any importance of family history? Yes. So there might be genetic or hereditary diseases, okay, which might be common in that particular. Okay. So then occupational history. What will you ask in occupational history? Yes. So I told about his occupation. In which occupation he belongs, there might be association. Okay, there might be association with that particular group of disease. Okay. Then drug history. Okay, whether he is under any medication. Okay, particular group of drugs which he is taking. Okay, that things. Okay. Then social history. What will you ask in social history? About his social interaction. Okay, whether he visited to certain places. Okay, whether any travel history is there. Okay, whether he is having any pets or not. Okay, so certain diseases might also come from that. Okay. Then you will ask in personal history. Okay, what will you ask in personal history? Personal history means the time he wakes up, from that time whatever he does. Okay, from his waking up till sleeping, everything will be covered in personal history. So suppose he had a well sleep last night. Okay, he had slept, so you'll be asking about sleep cycle. Okay, then waking up, after that he took a breakfast. Okay, that time you'll be asking about his diet. Okay, about his appetite. Okay, whether he's having appetite is good or not. Okay, whether his appetite decreased or whether he's not having any sensation of. Okay, then about his diet, whether he is a vegetarian or non-vegetarian. Okay, so certain disease might come from vegetarian. Okay, can you tell any disease which might be present in a non-vegetarian vegetarian person? Yes. So vitamin B12 deficiency might be present. Okay, in a vegetarian diet. Okay, then about his. So after that, after taking food, the food will get digested. Okay, then he will defecate. Okay, so you have to ask about his bowel and bladder habits. Okay, whether he is passing stool frequently or not, whether he is having difficulty, whether the stool is hard or not, whether he is having diarrhea as related symptoms. Okay. Then again you have to ask whether there is any relieving or aggravating factors. Okay. And the whether there is mucus mixed or blood presence. Okay. The color. Okay. These things. Then similarly for urine also you have to ask. Okay, whether it is having difficulty in passing, or it is increased or decreased. Okay, having pain. Okay, these things. Okay, then anything in personal history, any index which says that you are fit or you are malnourished. Anything? Yes, that is BMI. So this will be coming in personal history. Okay, whether that patient is fit or not, okay, within normal range or not, whether he is obese, whether he is malnourished. So this will come in BMI. Okay. So, and another thing is left, that is socioeconomic history. Okay. There you will ask what the income source. Okay, how much the particular person is incoming. Okay, whether he is below average or above average. Okay, low, middle or high class. Okay, you have to ask this also. You have to write in months. Okay. Okay, another thing will be allergy history. Okay, if he is having any allergy to certain substances. Okay, he might be allergic to certain foods. He might be allergic to certain medicines. Okay, and pets. Okay. Okay. So you have to learn how to take a proper history. Okay, this will give you clues. Okay, to diagnose further. Okay, if you can't take a good history, if you can't be a good history taker, you can never diagnose a person. Okay, this is the first step. So you have to learn this. Okay, you have to develop this skill. Okay, this will come under practice. Okay, you can directly learn from the slides. Okay, by taking history, you will be a good history taker. Okay, so now the rest of the part will be taking in that hall. Okay, so you divide into 4 groups. Okay, and come there, and we'll be taking the rest of the part. Okay, MBBS in Shantiniketan Medical College, and I will be examining you and asking you certain questions. So if you are comfortable with this, I will proceed. Okay, so if he is comfortable, are you comfortable?
Yes.
Okay, so the subject is comfortable. Okay, so we have taken the consent. So do you remember anything about general physical examination from your previous classes? So yes, the first thing is when the patient enters, we have to check the gait. Okay, whether the patient is walking by his own, whether he is taking any support, whether he is limping. Okay, that thing we have to see. Then his build. Okay, whether he is malnourished, obese. Okay, these things. Then so the common things which we always see or ask is in general physical examination. The first one is pallor, then icterus, then clubbing, then cyanosis, then edema, then this is lymphadenopathy. Okay, then scar marks, the main points. Then dehydration. Okay, these things. Have you covered the icterus?
Yes.
Okay, so these things. Okay, these points we mainly covered. But as this is our respiratory, so we'll be excluding certain physical examination, general physical examination. Okay, like icterus. Okay, we cannot get an icteric patient in a respiratory case. Okay, then the extra things which we will be adding here is the like any venous pulses. Okay, present there. Any scar marks. Okay, the symmetry of the chest. Okay, then any mass which is present, okay, which can be seen from the naked eye, okay, in the chest part, okay. Then any pulsations, okay. So first we go for pallor, okay. So what are the sites we look for pallor? Eyes. Which part of the eye? So the patient, you have to be in a sitting position, okay. Then in presence of bright light, we'll examine him. Can you open your glasses? So this is the lower palpebral conjunctiva, okay. This is the lower palpebral conjunctiva. So here we'll be looking for pallor. Then any other sites? Do you know? No, not upper.
So in the hands.
Yes, in the palms, okay. Palms mainly over the creases, okay. We have to compare our hand with the patient's hand, okay. Then any other side? In tongue also we can, okay. Fine, okay. Then after pallor, then icterus. So I told now icterus will be excluding, okay, as is a respiratory case, okay. So next comes is clubbing, okay. So how will you see whether the patient is having clubbing or not? So how will you understand? You wear it. How you will understand? So we will tell the patient to just close his thumb fingers, okay, and we will observe the space, okay. Normally this is diamond shaped, okay. So normally it is more than 180, so there the angle will be obliterated. So if the angle is obliterated, the angle will be shortened, okay. So this is known as this is known as Shamroth sign, okay. Shamroth sign, okay. Then another one test is there to identify whether the patient is having clubbing or not. This is known as fluctuating test, okay. So how the fluctuating test is done? We simply hold the fingers, okay, mainly if you are holding the index finger, we will fix the tip and the flexor part, okay. Then we will press with our middle finger like this, okay. Clubbing is the bulbar enlargement of the nail bed, na? So there will be growth in the tissues of the space, in the spaces, nail beds, okay. So this will give enlargement of the space. So if the tissues enlarge here, so if we press with this finger, we will be feeling with the other finger, okay. If there is any push, we are feeling the pressure with our left middle finger. So this confirms that the patient is having clubbing, okay. Then this is the test, okay. Yes, with the middle finger, with the right finger, if you are a right-handed person, okay, you can do it yourself. We will fix it, okay. With this finger, we will just press it like this, and we will feel with this the other finger, okay. If there is enlargement, we will definitely feel, okay, the pull, okay, or the push, okay. So there are various grades also, okay. There are 1st degree, 2nd degree, 3rd degree, 4th degree, okay. The enlargement increases or enlarges towards the wrist, okay. The final degree is the grade 4, where the wrist gets swollen, okay. This is massive, okay. So there are respiratory causes where we can get this, okay. Then comes
in the wrist, how will we check?
The first one is the confirmation, okay. The wrist, it will be swollen up, okay. It will progress, then the nail will get like parrot bead appearance, okay. It will get, and then the final one the wrist will get enlarged, okay. Then after clubbing, you want to go for edema, okay. So edema, how will you? Okay, so how will you do? Can you show me? So we will tell the patient to expose his ankles, okay. Can you expose your ankle? So after exposing his ankles, mainly, yes. So we will press the middle malleus and wait for 5 to 10 seconds, okay. After waiting for 5 to 10 seconds, we will remove our finger, okay. If there is a pit in the periphery or the middle malleus, that means he is having edema, and this is a type of pitting edema, So one type is pitting edema, okay, where there is accumulation of fluid in the extracellular spaces, okay, and another is non-pitting, okay, like in case of elephantiasis, okay, filariasis, okay, there is obstruction of the lymphatic flow. There, it is swelled, the lower limbs, and then where the pitting is absent, okay. This is edema, and then we'll go for cyanosis. So, what are the sites we can check for cyanosis? Can you tell? Okay, so in cyanosis, they are also of two types. Okay, one is peripheral and another is central. So, in peripheral, we look for the peripheral cyanosis in the peripheries, like the fingertips. Okay, in the toes also we can check. Okay, this mainly comes due to peripheral vascular diseases. Okay, there is decreased flow. Okay, then central cyanosis. Okay, central cyanosis where we will check tongue, which part? The base or lower part of the tongue. Okay, so can you open your mouth? So if this is the upper part, can you pull your tongue above? So this is the lower part. Okay, so any other place, any other site where you can see cyanosis? Yes, in the ears also, in the ear lobes. Okay, then in the tip of the nose, lips. Okay, so here we can see for central cyanosis. Okay, then next. Lymphadenopathies. Okay, lymphadenopathies means swelling of the lymph nodes. So how will you check whether the patient is having any swelling or not? So there are certain groups of lymph nodes in the neck, in the axilla. Okay, so in the neck, how will you check? We'll tell the patient to sit, and we'll stand the back side of the patient. Okay, then we'll start palpating. Okay. There are certain group of lymph nodes like anterior, posterior, preauricular, auricular, submental, okay, supraclavicular, okay, cervical, okay. We will palpate in those areas, okay, and see whether there is swelling of any lymph nodes or not, okay. Then the axillary part also you can palpate it, okay. If there is swelling, you can check it there also, okay. Then dehydration. So how will you see dehydration? Okay. One is tongue. So in tongue, what will you see? Dry, and whether there is formation of any crackles, okay, or cracks in the tongue, okay. This we can get in severe dehydration, okay. Normal patient won't be present, okay. Then in the eyes, it will be shrunken, okay. Then lips can be dry, okay. But, so then one test is there, okay, to evaluate, okay, but it will be positive in severe dehydration, okay. So we will pinch, okay, the skin, and we will hold for 5 seconds and then leave, okay. If it is taking more than 4 to 5 seconds, okay, then the patient is having dehydration, okay. This is skin test, okay, to confirm dehydration, okay. This will be in case of severe dehydration, okay.
5 seconds for what?
We will hold for 5 seconds and then we will release. If it is taking more than 4 to 5 seconds to get back, or okay, then we can say that it is dehydrated, okay.
Older people, if we
Yeah, you can in older people, if the so this is just a test, okay, to find out clinically, but there are other symptoms you will be comparing, na? So with just simple this pinch test, you won't be confirming. Like you will see the tongue, the eyes, okay. There will be various other factors also, okay. This is just a test clinically, okay. So next is what? Then we will see any venous pulsation is present there or not. Venous pulsation means here one vein is present, the jugular vein, okay. So in case of pulmonary hypertension, there is increase in pressure in that vein. So this will get prominent in the necks, okay, in the neck of the patient. So how will you examine or how will you measure? So if it is more than 8, okay, more than 7 to 8, then we normally consider it is high, okay. So we need a measuring tape or scale.
7 to 8 millimeter.
Mm. Okay. So here we need a scale, okay. We'll tell the patient to lie in supine position, okay. Then we'll flex the patient to 45 degrees, okay. If this is an adjustable bed, then we can adjust, okay. So we'll tell the patient or bring him to an angle of 45, okay. Then from the sternal angle, you know the sternal angle? Can you open your shirt more? So how will you identify which is the sternal angle? So you know the parts of the sternum bone, okay. This is known as the manubrium, okay. The upper one is known as the manubrium, and then the body, and then the Zipf's process. Okay. So the joint, okay. This is known as manubriosternum joint. Okay. This is also known as sternal angle. Okay. So here, from here till the maximum pulse which is been seen, visibly pulsation is present. So we will, after tilting the patient, the neck will become coming a bit more upwards, na? So from here we will take the scale, and then the maximum, the maximum part where the pulsation is being seen. So we will measure from here the height, okay. So if it is more than 7 to 8 mm of water, then it is high. So it is jugular venous pressure, okay.
How will we locate the sternum? How will we locate the sternum and find the sternum?
So there is a depression here, okay. The manubriosternal joint, there is a depression here, okay. And when you feel it, okay, with your fingers, there is a depression. You can easily feel there is a joining, okay. This is the sternal angle or the manubriosternum joint, okay, here. So the jugular venous. And another thing is, in respiratory cases, we normally see that the patient is maximum categories of patient are smokers, okay. When you will be taking the history, you will also ask whether the patient is smoking or not, any addiction present there or not, okay. How many, if he is smoking, how many sticks he is smoking, okay. Whether with like tobacco, whether he is taking any other drugs or not, okay. Certain group of drugs can be smoked also, okay, like cocaine, okay. Then cannabis, okay. You have to ask that also. So if he is a smoker, so we will observe his hands, okay. There will be nicotine stain in his hands, okay. We have to observe this also, okay. Then another in respiratory cases we can get, that is flapping tremors, okay. So we'll tell the patient, we'll tell the patient to straight his hands, okay, like this, okay, and then we will just press his hands like this, like this. And if he is having flapping tremors, this is a neurological disorder, okay. If he is having flapping tremors, so in respiratory cases, due to accumulation of carbon monoxides, okay, excess, okay, that time the patient will flap like this. This is seen in various other diseases also, okay. So when we will press like this, okay, towards him, and he will just flap like this, okay. This we can get in respiratory cases also, okay. Okay, this is known as flapping tremors, okay. So then we'll can you expose your shirt more? Just open it. Okay, be comfortable, okay. Okay. So after exposing him, so we will see the venous pulses we have done, okay. Then we will see any scar marks is there or not, okay. The symmetry of the chest, okay. Normally the shape of the shape of the chest is elliptical, okay. elliptical, so we will see the symmetry of the chest, okay, whether the symmetry is equal in both the sides or not, whether we will observe his breathing and the shape, okay. In certain diseases like scoliosis, kyphosis, have you heard the term scoliosis, kyphosis? In scoliosis the spine like bends like this, okay, there is lateral bending of the spine. So in those conditions the patient, the rib cage will be pressed in one side, okay, the symmetry won't be there, okay. Then other condition is kyphosis, where there is forward bending, okay, the patient leans forwards. Have you seen in old patients? I think so. There asymmetry might be present. So other causes are like a pigeon shaped, okay, the chest will be, the anteroposterior will be increased there, okay, the shape of the pigeon, that's the shape of the pigeon, okay. Then another is where the chest inrolls itself, okay, the median part inrolls itself inside. There what happens, the anteroposterior diameter is very less, okay. So these are the various other condition where both the things can be present, like this is kyphoscoliosis, okay, where both the things, deformities are present, okay. Then so we will look for the shape, okay. Now mainly these things, okay. Then after that we will see, we will go for the systemic examination, okay. In systemic examination the first point is what, the 4 parameters are inspection, palpation, then percussion and auscultation, okay. These are the 4 parameters, okay. So now in inspection what will you do? We just see, we just observe the patient, okay. So in observation what are the things we see? First is the symmetry, the shape and size of the chest, okay. Normally it is increased in this direction, okay, laterally, okay. So so we will observe his breathing, okay. So in breathing whether it is equal in both the sides, okay. So here also we will see any marks is present there or not, okay. Like do you know PTG? So there will be superficial, there will be clotting of bloods, okay, in the chest, okay. Then like there was spider nevi, you have heard the term spider nevi, okay. There will be dilatation of the arterioles, okay. These things we see. Then in the skin there will be small pins, like PTG means pins like spots, okay. This is known as PTG, okay. Then spider nevi is another thing, okay. It looks like a spider wave, okay. It will be central, there will be one alveoli arteriole and the rest will be spreading like this, okay. We can see this. Then any scar marks, okay. Is there any significance of scar marks? Scar marks?
Previous surgery.
Yes. Surgeries or operation had been by the patient, okay, had been happened. So with that scar mark we can identify. Then what we see, any enlargement or mass, okay, or with our naked eye or visual eye, if it is there we can see that also, okay. So in inspection we see this, okay. Then we'll go for palpation. So what do we do in palpation?
Tell the patient to breathe in. Tell the patient to breathe in.
So I told the symmetry. So in visually you saw, okay, the symmetry is fine, okay, but to confirm it you have to palpate it. So the symmetry, how will you confirm it, okay? We will place our hand in the lower ribs, okay. Then we will touch our middle finger like this, okay. The skin must be separated from our fingers, okay. The space is separated from our fingers, okay. We will press it and then we will touch it, but not touching the skin, only the thumb. And then we will tell the patient to breathe. Can you breathe? So Normally it is around 5 to 6 centimeters. Okay, if the distance is increased, okay, you can suspect that there is some abnormalities. Okay, suppose if one of my fingers, okay, this is the middle part, when expanding na, if this part is static and this part is expanding, okay, so this part this is the left side na, so there is some abnormality in the left side for which he is not being able to breathe or expand his chest, so some deformity is there. Okay, so by this we can identify if any deformity is present or the symmetry is not maintained. Okay, okay, then symmetry. So we are palpation. In palpation, this is the symmetry we are confirming. Okay, suppose if there is any symmetry which is in any other of the chest is not equal, okay, by seeing we can identify, but we have to confirm it. So this is the process. Okay, so normally when the patient takes the breath, normally it is abdominothoracic. Okay, normally it is abdominothoracic. So can you see when he is breathing, it is abdominothoracic or not? Abdominothoracic means when he is inhaling, the abdomen rises up and then the chest. Okay, normal conditions, this is abdominothoracic. Okay, so in certain diseases it might be thoracoabdomen. Okay, like in females, okay, we can find like in pregnancies, in ovarian tumors. Okay, in these certain conditions we can get thoracoabdominal. Okay, so this, so after that what comes is auscultation. So do you know the no palpation, there are things, okay, left. So do you know the intercostal spaces? How do we count?
Sternum, there is the second rib. In the second or third rib, there is the second intercostal space.
So first you have to. One point is there. Okay, so in here na, in palpation, one more thing is there. Okay, like we have to track the trachea. Okay, like this. Okay, this is our sternal border of the clavicle. So we will press our ring finger and the index finger, okay, here, and then we will trace the trachea from above downwards, like this. Okay, from above downwards. So if there is any shifting or deviation, okay, like if there is any fluid or extra air, okay, due to any infection or injury, okay, the trachea might be shifted. Okay, there are conditions like in pleural effusion, okay, then in case of pneumothorax, okay, it might shift towards it. But there are certain conditions where the trachea might shift opposite direction. So this is contralateral deviation. Okay, this is ipsilateral and opposite direction. So if the deformity is here, the trachea will be shifted there. Okay, this is known as contralateral deviation. Okay, so this is ipsilateral, where the deformity is there, it is shifted towards that. And contralateral means opposite direction. Okay, so what are the conditions? So some conditions are pneumothorax, and another one is fibrosis, okay, or collapse. In these conditions, the trachea will be shifted towards the opposite direction. So in palpation, always start from the trachea, okay, from here, okay, like this, from above downwards towards the sternal notch will come. Okay, you can easily see that whether the trachea is shifting or not. Okay. So where I was in the intercostal spaces. So how will you count those spaces? So I told na, if this is the manubrium and this is the sternum, there will be a break or depression. Okay, there will be a space. So this is the sternal angle. Okay. So here, what is the significance of this rib of this joint?
This marks that L4 vertebra with that line that marks the upper superior medial sternum.
So here there are certain structures present here. They have their own significance. Okay, I think. Previously I told. Okay, so here to count the ribs, this is the easiest way, or the intercostal spaces. Okay, here the second rib comes and attaches. Okay, here. Okay, so if we can identify the second rib, it is very easy to count the intercostal spaces. Okay, so press here. Any one of you come here and press. Okay, just see if this is the space, the second rib. See, second rib is there or not? If this is the space, okay. So this is the second rib, not this one. Okay, the rib comes from back side, na. It will be curving and attaching, na. So this is the second rib. Okay, so if this is the second rib, you can feel it. If this is the depression, see. So this is the second rib. So if this is the second rib, the above one is first rib. So this is the first intercostal space, between the first and the second. So between the second and third is the second intercostal space. So here we will be counting, or we will be seeing in palpation we will be seeing the apex beat. Apex beat means the impulse or the beat of the heart coming from the apex. The heart is. So if this is the joining, this is the manubrium and this is the sternum, you can see the depression. So here if you trace, is there any bone attaching coming and attaching here? Okay. So how will you palpate the apex beat? Okay. So it should be counted from in the sixth intercostal space. Okay, sixth intercostal space. It will be in the mid clavicular line, medially to the sternum, at least 1 to 2 centimeters. Okay, so you will just simply touch here. Okay, first of all you have to count it. So if this is the first rib, okay, then this is the second rib. So the first intercostal space is above. If this is the second rib, then this is the second intercostal space. This is the third. This is the fourth. This is the fifth, and this is the sixth. So here we'll just press. We'll just keep our hand here. Okay. So here, if you can feel the apex beat, okay, we'll just locate it. Okay, it will be at least 1 to 2 centimeters medially to the sternum. Okay, this will be in the mid clavicular line. Okay, so suppose I got the beat here. Okay, so sometimes if we can't get the beat here, we will just tell the patient to shift his posture towards his left lateral. Okay, laterally we'll just tell the patient. Okay, so like this. Okay, it is usually not done if it is not found. Okay, so if there is any beat, okay, we will just simply observe. Okay, so there is little. Okay, it is not very much, but there is little. Okay, understood now this part? What is the significance? Why I am shifting him? So the gravity will pull it, and then we can feel it. Okay, this is the main thing. Okay, here then this in this thing we see these things. Okay, in palpation. So if there is any mass or something, okay, we can palpate. Okay, in palpation this will come. Okay, after palpation we'll go for percussion. So what is the significance of percussion? Can you tell? So previously what sounds we heard in GAT? Dull and tympanic. Okay, so here will be resonant or dull. Okay, these two sounds here. So how will you percuss? Do you remember? So okay, so there are terminologies. Okay, so this is the flexor and this is the pleximity. Okay, this is the plexor and this is the pleximity. So the pleximity is the finger which we keep in the intercostal spaces. Okay, it should be horizontal to the diaphragm. Okay, this should be firm and fixed, and these two fingers should be separated. Okay, and in here, where will be percussing? In the yes. Okay, this is the terminal or distal. Which phalanx is this? Okay, so here, not in the joints. Okay, in the bony part. So what is the procedure of percussing? So the wrist and the elbows must be in one direction. Okay, and only the movement should be from the wrist. Okay, it should be in regular interval, not too fast, not too slow. Okay, so we have like this. We'll put our finger and then we'll percuss. Okay, like this. But here my elbow is raising now, so it is not possible to percuss a patient in standing position. So this must be done in sitting position. But in examiner, in front of examiner, you cannot stand, you cannot sit. So you must do it in standing position. But when he will be asking you, say these points. Okay, you will understand, then you know it. Okay, so this way we will percuss. Can you hear the sound? So we will go down. Okay, like this. Like this we will go down. So at sixth intercostal space there will be dull sound. This is what?
Because of
Liver. Okay. So here this is in the mid axillary. Okay. Here the margin of the lung also presents here. Okay. In the sixth intercostal space. Okay. In the mid axillary line. This is the mid clavicular. In the mid clavicular line. Then in mid axillary line we will again percuss. Okay. Like this. So in 8th intercostal space, this is the next border of the lung. Okay, the lowest margin will come in the 10th intercostal space in the posteriorly. Okay, one is in the mid axillary line, one in the axillary line, and one is in the posterior direction. Okay, this marks the margins of the lower border of the lung. Okay, 6th in the mid axillary, mid clavicular, 8 in the mid axillary, and 10 in the posterior. Okay, ठीक है? Any question?
सर वो बीट वाला जो था
Beat? बताओ.
सर बीट बोल रहे थे
I want to repeat. You want me to repeat? Okay. So this is felt in the mid axillary line. If this is the not mid axillary, mid clavicular line. If this is the mid clavicular line, okay, then in the 6th intercostal space, 1 to 2 centimeter medially to the sternum. Okay, here we just keep our hand and just feel. Okay, and mark the point. ठीक है?
of what beat
Apex beat, yes. ठीक है?
why happens
Beat of the heart.
okay
If the heart is palpable,
takes beat right
yes. If the heart is palpable, if the heart is enlarged, okay, that time we can feel it. Okay. So this comes in. Okay. One more point is left in palpation is the vocal fremitus. Okay. Vocal fremitus means we will tell the patient to speak certain words, okay, or pronounce certain words like 1 2 3, like 999 or ram ram. Okay, these things, and then we will just feel it like this. Okay, can you utter these words? 1 2 3 like this.
1 2 3 1 2 3 1 2 3 1 2 3 1 2 3 1 2 3
So this way we see the vocal fremitus. Okay. So what is vocal fremitus? So when the sound is produced in the larynx, it transmits through the tubes. Okay, the trachea, the right and the left bronchus. Okay, this transmits the sound or the vibrations to the lung. Okay, the parenchyma. So we should compare it, okay? Like if he is pronouncing, then left, right, like this, okay? It from above downwards, so we will go, okay? This is the infraclavicular area, this is the mammary area, and this is the inframammary area, okay? So like this, we will just see. One of you just observe it. Try. Can you speak?
1, 2, 3.
Just touch here and then here.
1, 2,
Lightly.
1, 2, 3. 1, 2,
Can you feel the vibration?
1, 2, 3.
So when you will be going lower, the vibration will be diminishing. Okay?
1, 2, 3.
Can you feel?
1, 2, 3.
It is decreasing, na? You try.
1, 2, 3. 1, 2, 3. 1, 2, 3. 1, 2, 3.
So with his
1, 2, 3. 1,
utterance, we will just touch and feel. Okay, this will be in palpation. Okay.
Sir, with this, what we do?
Yes, I am coming. So the conduction is proper in this. So its significance is that he is not having any respiratory disease. So in certain respiratory diseases, this comparison might be there might be an imbalance. The symmetry might not be same. Okay. So if there is any conduction defect, okay, like in asthmatic patients, like in COPD patients, this conduction will be diminished. Okay. Any obstruction in the throat, okay, any tumor, any growth, this might also decrease the. Okay. In certain diseases, it might increase. Okay. Like in any infections, okay, like in TB, okay, there formation of cavities if there is formation. Okay. In pneumonias also, if there is any formation of cavities or consolidation, okay, there the transmission increases. Okay, so one side it will be normal, one side it will be increased. Okay, this will come when you practice. This is just for your knowledge. Okay, so this will come in palpation, percussion thing. Okay, done. So then auscultation. So in auscultation, what we see? Sounds. Okay. Normally the sound is what? In auscultation, when we resonance, and this is for percussion. But in auscultation, when you hear with our ears, what is the sound? Normally it is vesicular. Okay, we say that it is a vesicular sound. Okay, bronchial sound we can hear also here. Bronchial sound will be in the bronchus, mainly in the bronchus, in the trachea we can find. But the rest of the parenchymal part, it is said normal when we hear vesicular sound. Okay, so we hear these sounds. Okay, then another clinical experiment, like in auscultation we have done. This is the vocal fremitus, and now this is vocal resonance. Similar way, we will just auscultate from above to downwards, various parts of the chest. We will auscultate anteriorly also, we will auscultate posteriorly also. Okay, so we need stethoscope for that. Okay, so do you know how to wear it? How? Show me. So everybody is not allowed to wear the stethoscope. Okay, only the person who earn it, okay, can wear it. Okay, so you wear it. Show me how to. So the earpiece should be medially, okay, towards the drum. Okay, then what is the part? This is the diaphragm. Okay, and this is
Chest.
yes. So how will you auscultate? So is this on or off? How did you know? Okay, there is a lock. Okay, so there is a lock which we can switch off or switch on. Okay, so how will you auscultate? You are also having any problem? Huh? How will you auscultate? So we'll go from above downwards. I told na. Similar way. So here we won't say the patient to auscultate certain terms or things, okay? So just we'll tell the patient to inhale and exhale, okay? So now take a deep breath and exhale, okay? One thing is, always it is better when the patient inhales or exhales from the mouth, okay? It is better heard, okay? Without making any noise, okay? Can you inhale and exhale without making any noise? Do it once.
Doing it with mouth.
Okay. So it is better heard when it's taking from the mouth. Okay. So do it. How will you auscultate? How? No, with the diaphragm. Okay. How will you auscultate? So it has to be in the space, okay, not on the bony surface, okay. So if this is the supraclavicular, this is the infraclavicular. So this is the infraclavicular. So from the infraclavicular area we'll start. So once you hear the sound from here, the vesicular sound, then you shift from here, from the left to the right, okay. It has to be symmetrical, okay. If you are checking one side, you have to go for the other side. So this helps us to know whether this patient is having any deformity, okay. Can you hear the sound? How is the sound? Lubbed up. Okay. So here there are certain cardiac areas, okay, pulmonary areas, then aortic areas, okay. There are certain areas. So this is the sound of the arising from the heart, okay. So can you take breath? A bit fast. So we have to hear the sound from the upper part, okay, then towards the lower lobe, okay. These are the lower lobes. So after hearing the sounds from the anterior part, the anterior chest, then we go for the posteriorly, okay. So then we'll tell the patient, okay. So this is examine the patient in sitting position, okay. Can you sit? Okay. So we will expose his back. Can you expose? Okay. So now when we auscultate or palpate the back, okay, always tell the patient to bring his hands like this, okay, or like this, okay. Can you like this? So this, what is the purpose of doing this posture? So if he is in normal posture, can you relax your hands? If he is in normal posture, in the back there is one bone. This is what bone? Scapula. So this obstructs the area. Okay. The benefit is, if he is pulling his hand like this, it will just pull it. Okay. This will give much area for you to examine. Okay. This will open up the back. Okay. So now again we will auscultate him. Okay. Suprascapular area. Okay. Like this, both sides. Can you breathe? Okay, now we are getting much more area. So this part was obstructed. Now we can auscultate. Okay. This is the infrascapular. Okay. This is the intrascapular part. Okay. This is the infrascapular. Okay. This is the mid scapular line, okay, the lines which passes, okay. So this way. So this is under auscultation, okay. there are two sounds. I told you the one is bronchial sound, which you can hear in the bronchus, and the rest parenchymal area will only hear the vesicular sound in normal conditions. Okay, so there are some added sounds we can hear, like in case of COPDs, the person who is smoking for long term. Okay, then taking any inhaled smoke. Okay, like in village areas, like our grandparents used to cook. Okay, there was smoke na. So in long-standing cases, this can also come to COPD. Okay, this can also become to COPD. Okay, so this is a type of obstructive airway disease. Okay, COPD is a type of obstructive airway disease. Okay, then in case of bronchial asthmas, okay, these cases we can hear certain added sounds. Okay, so what are the added sounds? Can you say? So in percussion, suppose in auscultation, percussion, and palpation. Okay. So they are mainly in percussion and auscultation. Other importance is that if the patient is having pleural effusion, okay, so there is accumulation of fluid in the pleural cavity. So the part of the space where we are getting dull sound, okay, that can be also a confirmation for pleural effusion. So there the sound will be dull. In percussion, it was supposed to start from 6th. Suppose it started from 5th or 4th. So this might help you in diagnosis. Okay, this is not a confirmatory but a differential diagnosis. Okay. Similarly, in case of auscultation also, if you get a dull sound, the most of the vesicular sound must be heard from the parenchyma, the anteriorly and the posteriorly. So if there is any diminution in particular area, so this might also help us. Okay, if the sound is dull, it is not being supposed to dull. Okay, first it might be an added sound, then it is supposed to be dull. Okay, so in normal cases you won't find any dull sound. Okay, or stony dull. Okay, so what are the added sounds? So we will know what are the added sounds. So sounds like ronchi. Have you heard the sound like ronchi? Ronchi or wheeze. Okay, so this is a musical sound. Okay, mainly it arises from the upper respiratory tract. Okay, when the patient expires or exhales. Okay, this will be heard. Okay, this is a musical sound. Okay, then another sound is this we will find in case of bronchial asthma. Okay, where there is the bronchus is being obstructed or narrowed. Okay, in COPD cases also, where the bronchus is being obstructed, it is being narrowed, and thin line of air might pass, that will produce the musical sound. Okay, so other sounds are like crepitations. Okay, so what is crepitation? Crepitation means small explosive sounds like bubbling sound, clicking sound. Okay, this is normally we hear in the lower part of the respiratory system. Okay, so this might suggest us that there might be any presence of infection or not. Okay, in certain infectious cases we hear these types of sounds. Okay, or in certain condition where there is accumulation of fluid also, that times also we can hear this clicking or bubbling sound. This is known as crackles. Okay, or crepitations. Okay, these are small explosive sounds. Okay, so another sound is there. This is known as pleural rub. Pleural rub means what? Yes, one term I use now there. Pleuritis. Have you seen pleuritis? Okay, this is what? This is inflammation of the pleura. So in inflammation of the pleura, we hear pleuritic sound. Okay, and the patient will tell that I am having pain. When you will tell the patient to inhale, I told you deep inhalation. That time he will say that the pain is aggravating. So this is the way you can say that the pain is coming from the pleura. Okay, there is inflammation of the pleura. So how will be the sound? How will you hear the sound? The sound will be when you suppose a snow fall has been happened. Okay, the snow has fallen. Okay, and you are naked. Your foot is naked. Okay, so when you slide your foot, the sound will be coming. Okay, this will be a type of rubbing sound. Okay, This is known as pleural rub. Okay, so you might mistaken this sound with another sounds, like various sounds, like if so the procedure of auscultation is, the first step is you have to expose the chest or the part where you are being ausculting. Okay, there shouldn't be any clothings, okay, which obstructs your transmission of sound from the chest to your stethoscope. Okay, the part which you are examining must always be exposed. Okay, so this way you can exclude the added sound, extra added sound. Okay, means false sound, like the same type of sound like the pleural rub you can hear if there is any clothings or any hairs. Okay, any rubbing sound you will hear. So this is a false sound, na? This is not coming from the pleura. So this way you can exclude. So this one, okay, and other tests are also there. Okay, like one test was coin percussion, I think. Okay, this is not being studied now, but you will get when you pass to the successive years when you cross your academics. Okay, like there are tests which we can confirm whether there is accumulation of fluid or not. Okay, like in case of pneumothorax also. Okay, the sound will be like coin. The percussion which we do normally with the fingers, we will use the coin with. Okay, with the help of the coin we will be hearing the sound. Okay, this will you will be coming in our academics. Okay, this much. Okay, anything left? Okay, can any one of you just recap, or all together you can help yourselves? Just recap it.
Sir, you did this one. What was this?
This is for symmetry.
Yes, symmetry. Sir, can you show me?
Wait, let me check. You guys are only taking. You guys are not giving anything. Let me check how much attentive you are. You are able to take it or just hearing coming to class? First what I said. So general physical examination, na? So in general physical examination, what will you see? First we will observe the patient entry, then gait, okay, whether how he is walking, whether he is having support or not, then okay, then we will introduce ourselves, then we'll take his consent. Okay, if he gives, then we'll proceed. Okay, then
First we check for
pallor. So what are the sides? Conjunctiva, then palms. Okay, palms and the creases. We'll compare with our hand. Okay, then no, other side. Eyes, palms and
Tip of. No, that was for toe pallor.
tongue.
Yes.
Okay, then icterus. Icterus is not will not consider this in respiratory system. Okay, then cyanosis. Okay, cyanosis. There are two types. One is peripheral, one is central. So peripheral, where is he? Fingertips and the toes. Okay, this is peripheral. Then central is base of the tongue. Okay, then okay, earlobes and lips. Okay, then cyanosis finished. Then next is okay, dehydration. So in dehydration,
Check the tongue.
where will you see? First the site, tongue. What will you see in the tongue? Dry or cracked. Okay, then eyes will be shrunken. Okay, then skin test, pinch test. Okay, then
clubbing of nails.
clubbing. Okay, clubbing. How will you see clubbing? Okay, this is known as, we'll tell the patient to join his thumb and then we'll see whether it is diamond shaped or not. This is known as Shamroth. Okay, Shamroth sign. Then any test? Any test to see whether the patient is clubbing present there or not? How will you see? We will fix the distal phalanx, okay, with our index and ring finger, and with the help of the middle finger, just
see the growth where it
on one side, on the dominant side we will press, and on the other side we will feel like this. Okay. So this is a conformity test for clubbing. Then edema. Okay. So edema, how will you see? Middle villus. Normally the sites are in the lower limbs mainly. Okay. This can be also present in the upper limbs. Okay. If there is gross ascites, okay, it will be ascending from the lower limbs. It will come towards the upper limb. Okay. In lower limbs where? Middle malleolus. Okay. How will you see? We'll press the area for 5 to 10 seconds. Then we will release. So what will you see? Okay. If there is pit formation. So if there is pit, then it is a type of pitting edema. Okay. Then
if in non-pitting there will be swelling.
Swelling. Okay. So there are certain conditions. Okay. Where we will find pitting and non-pitting. Then lymphadenopathy. Okay. Lymphadenopathy. How will you see? We will stand in the back of the patient, and then we will palpate the various angles of the neck. What are the angles? Can you say? So the sides are supraclavicular, then mental, submental, preauricular, auricular, cervical. Okay. So we'll palpate and see whether there is any swelling of the lymph nodes out there. Okay. And we also palpate the axillary area. Okay. Okay. Then anything left here? One more thing is left here is the JVP. Okay, this is the jugular venous pressure. How will you see? How will you see the jugular venous pressure? Supine position. Then 45 degree. We will bend him. We'll tell to or elevate his head. Then at the 45 degree angle, we will see the greatest pulsation. Okay, the greatest pulsation, and then from the sternal angle, we will take a scale, okay, and the maximum distance. So it is around 8 mm. So if it is more than 8, the JVP is raised. Okay. Okay. Anything?
This one. All right at the pole.
Anything? One more thing I told na, in smokers you will see nicotine stains.
Nicotinic stains.
Okay, in the fingers there will be there. Okay. Yes. Another one is flapping tremors. So how do you see flapping tremors? We tell the patient to extend his hands and then flex it like this. And thus we will just pull. We'll just push him. Okay, towards him the hand, and then he will just flick like this. Okay. So this is the way. Okay. Then anything? Okay. In GP for respiratory case, this much is fine. Okay. Then what will you see? Then you will go for systemic examination. Okay. Systemic examination. First point is inspection. So what in inspection? What do we see? So the patient is in supine position. Okay. After lying into supine position. Then in inspection we just see and observe the patient. So what are the things we see and observe? Symmetry. Okay. First we see the trachea. Okay. If there is any deviation. Okay. With our naked eye. First is this. Okay. No. In inspection we just see. Then in the chest what do we see?
If it's elliptical or
Yes.
elliptical.
Whether there is the symmetry is there or not. Okay. Whether there is any enlargement or not. Any part of the chest is not moving. Okay. There is asymmetry. Okay. Then okay, scars. in inspection, we have to measure the rate also. Okay, one point is missed here. This is the rate. Okay, the normal rate is around 12 to 18. If it is more than 18, or it will be considered as tachypnea. Okay, it is less than 12, it is known as bradycardia, okay, bradypnea. Okay, so this point B must be also included in inspection. Okay, then the rhythm, okay, whether it is taking regular interval or not, whether it is fast, okay, whether it is irregular rhythm. Okay, this will also come here. Symmetry also taken, rate and rhythm also taken. Okay, in scars,
Yes. And those patches.
PTG, okay, and spider nevi. Fine. So this thing, any swelling visible from our eye, naked eye, this all will be covered in inspection. Okay. Then what comes is palpation. So what will do in palpation? Can you lie down? What will you do in palpation? First is the abdominal trachea. Always start from the trachea. What we do is we put our index and ring finger in the where? This is the sternal. No, this is the sternal.
Clavicular
This is the sternal area of the clavicle. Okay, this is sternal area of the clavicle, and thus we will trace like this. Okay, like this we will trace. So any deviation we can suspect here. Okay, so if there is any deviation, it will be shifted. I told na. What are the two terms I used? One is ipsilateral and one is contralateral. Okay, so ipsilateral means if the trachea is shifted towards the affected side, and contralateral is if the trachea is shifted towards the opposite side. So what are the conditions? What are the two conditions I said for both? If the trachea is shifted towards the affected side, they are the pneumothorax and pleural effusion. Okay. Then what are the other conditions I said for contralateral deviation? One is the fibrosis, and another one is the no. One is the collapsed lung. Okay, these two terms. Okay. Okay. Then what else in palpation? I told. Yes, symmetry. So symmetry, how will you see? You will put your hand like this in the lower part, in the lowest part of the lungs, and then we will touch your middle finger like this, but this must be separate from the skin of the patient, and then we will tell the patient to inhale. Okay, can you inhale? Okay, inhale. Okay, so this is normally it is how much? 5 to 7. Okay, if it is more than that, it is okay, abnormal. Okay. So in certain conditions, one of my hand might not be expanding. So this is also a abnormality. Okay. So this the part which is not expanding, I am getting my hand movement is not having. Okay. Okay. So any more thing in palpation? What do we remember? Yes. What you are saying is the yes. This is the apex beat. Okay. How do you see the apex beat? Apex beat must be seen in the 6th intercostal space. But how will you know it is the 6th? Okay. Sternal angle. How will you identify this is the sternal angle? There will be a depression. Okay. This joint is known as manubrium sterni joint. Okay. Here the second ribs comes and joins. Okay. The space between the first and the second is the first intercostal space. Then second, third, fourth. Like this you will count. Okay. Then you will go to the 6th intercostal space. Okay. This must be in the mid-clavicular line and just medial to the sternum. 1 to 2 centimeter. We'll just keep our hand there and feel the apex beat. Okay. Then anything in palpation? So here we will, if there is any mass also, we'll just palpate this. Okay. So this one. Okay. Then what comes after palpation is percussion. So how will you percuss? What is the technique?
Middle finger by putting to middle finger.
Show me. Show me. So which is the flexor and which is the proximity? Flexor is the hand which we percuss, okay, and on the hand on which we percuss is the proximity. Okay, this must be in a parallel line or horizontal plane to the diaphragm. Okay, parallelly, and then we percuss. On percussion, we percuss on the bony one. Okay, the middle part. This is the distal. Okay, not on the joints. Okay, and these fingers must be fixed, firm. Okay, and must be separated from the middle finger. What is the movement from your hand? How will you move? The wrist and the elbow must be in a same plane, but it is not possible. Okay, you have to sit in front of examiner. You cannot. So you have to tell this must be in a straight plane, and it must be in a movement should be from the wrist. So this must be in regular interval, not too fast, not too slow. Try and just hear the sound. You have to practice this, okay? Without practice, you cannot get the sound, okay? If you are staying in home, you practice with your siblings. If you are staying in the hostel, you practice with your roommates, okay? Can you hear the sound? Can you hear? Okay. So this must be on the both side. Always auscultate on the both side. Percuss on the both side. Okay. If you are percussing on the left side, you should be percussing on the right side also. Okay. So normally the sound is resonating. Okay. Which is the in mid axillary and which is the lowest border of the lung?
6.
Is the 6 intercostal space.
It's 8. In mid clavicular,
In mid axillary it is 6 and posteriorly it is
posterior is 10.
yes 10.
Mid axillary is 8.
Mid axillary is 7.
8. Okay.
Mid clavicular is 6.
So from 6th position you will hear the dullness. Okay. Fine. So if you hear the dullness in the lower part of the lung, suppose before 8th or before 6th, so what will you suspect? There is pleural effusion. There is accumulation of fluid. Okay. Okay. Then percussion is done. Okay. Then comes the auscultation. Okay. One more thing is left in palpation. That is yes, vocal fremitus. What is the? How do we check vocal fremitus? Okay. So after that, we will just feel. Okay, like this. Can you say?
1, 2, 3.
Okay, we'll feel the vibration. Okay, this will decrease in when we go from above to downwards. Okay, then okay, percussion is complete. Anything you left in percussion? Okay, so percussion is done. Okay, then we'll go for auscultation. In auscultation, what we do? We hear the sounds of the lungs coming from the lungs. Okay, normally it is vesicular, but in the trachea, bronchus, we can hear bronchial sounds. Okay, so how will you hear the sounds? Show me. So this must be medially, okay? The airpass must be medially, and with the help of the diaphragm, we'll hear the sound and we'll tell the patient to breathe, okay? From mouth, okay? Okay, so Can you breathe? Okay. So always auscultate symmetrically both sides. Okay. Not on only single position. Okay. You are auscultating the left. You must auscultate the right. Then no. It is not like this. I told na. This is which area? This is the
Inferior clavicle.
infraclavicular area. Okay. So auscultation must be from the supraclavicular. Supraclavicular. Okay. Anteriorly. Yes. From this part. You must auscultate from this part. Okay. Not the bony part. Okay. Breathe. And this part. Yes. Okay. Then again come to infraclavicular. Okay. Then. Okay. Then. This is which part? This is coming. We are coming to the memory area. Okay. Okay. Then. Okay. After here, then you're going to be there. Okay. Then. Okay. This is the inframemory. Okay. Fine. Okay, when the patient expires the air. Okay, this might be in bronchial asthma. Okay, in COPD also we can get. Okay, but other sound is crepitations. Okay, or crackles. Okay, so what is crepitations? How does the sound of the crepitation look like? We can hear small explosive sounds. Okay, like bubbling or clicking. Okay.